Right from second MBBS, you are pushed into the wards or clinics, and you literally spend almost 1.5 to 2 hours every day in wards and clinics. And what is the use of that time? Communication you are building now, the quality of our communication, because in the future when you become a doctor, you have limited time, so you can't be beating around the bush to get one information from the patient. You have to be precise. MCQs will be cleverly designed in a way that if you have not spent time in the wards in your second prof to final prof and in your internship, then at least 5 to 10% of the MCQs you can't even touch. Hi guys, welcome everyone to MedEd. I'm Dr. Patil, and some of you might know me from the Reed Harrison series. I'm an educator for medicine, and today I'm going to talk about the big elephant in the room: wards or clinics. Right from second MBBS, you are pushed into the wards or clinics, and you literally spend almost 1.5 to 2 hours every day in wards and clinics. And what is the use of that time? A lot of students feel that this is just waste of time. Rather, I would use the time in solving MCQs on some app, or cramming some tables, or by hurting some mnemonics. And students feel that that's the right way of utilizing that time, and this wards or clinics are merely formalities. Is it so? Well, please remember guys, with the passage of time, the boards are becoming aware what you guys do in the medical college, and they want you to be back at the wards. So certainly the MCQ based exams also will start focusing on the time spent on the ward. I mean, they will not say that we will check your ward attendance and all, but MCQs will be cleverly designed in a way that if you have not spent time in the wards in your second prof to final prof and in your internship, then at least 5 to 10% of the MCQs you can't even touch. And we can see that happening in INICT and to some extent in NEET PG and in near future in FMG as well. So then that begs the question, if the wards are going to be that important, truth is, yes, they are important, not only from the exam perspective. You will become a better doctor only when you spend time in the wards. You will become a information hub if you spend time on the books and apps. You'll not become a better doctor. To be a good doctor, you need to have a ward exposure. So there is no debate about it. But the question is how to actually learn from the patients and not just stand there. Because that's what most of the medical students do, stand there. Someone takes the history, someone does the examination, some professor comes, asks some questions targeted at some kids gets lambasted, and at the end of it, today's clinic is over and I was just standing there. It happens with a lot of you. So how to actually learn from patients and not just stand there? So I will give you some important tips. Please follow that, and trust me, years down the line you will come back and thank me, sir aapne bol diya tha, you had said this and we implemented, and now I feel that I would not have been this confident as a clinician if I had not followed your words. So tip number 1, the most important thing you need to study or learn from the words is not examination skills, it's communication and history taking. So make sure you talk to the patients. Communication will make you better at taking history, protect you from getting sued, protect you from what would I say, protect you from losing patients, because in every sphere of life communication is the key. So if I can't communicate well to you of my knowledge, then I won't be a teacher on this podium. So I have worked on my communication. That's why I'm able to communicate to you in a language that you understand about whatever I have studied, right? So communication is the first thing. So go there and just start talking to the patient. In the beginning, you may not know what to talk. Ask the name, get the demographics, age, gender, where you come from, what do you do for living, all those. Just start. Once you start, slowly you will fall in the groove. So communication is key. Second, once you feel that, okay, I am now confident of talking to patients, there is nothing inhibiting. Now I want you to concentrate on what you ask. Means communication you are building now, the quality of communication, because in the future when you become a doctor, you have limited time, so you can't be beating around the bush to get one information from the patient. You have to be precise. So then Start reading about symptoms. History taking is important, but your history taking gets better when you understand symptoms. Like start reading about cough. So then you'll understand, okay, how a person coughs, what are the common causes, how do I differentiate between different causes. So in the cough, I would have told you in my PW Med live lectures that if you have a patient with cough, you need to know the duration, whether it is acute or chronic or subacute, because causes differ. So if you get that information, then you know I should be thinking of uh, acute viral pharyngitis in this particular case, or should I be thinking about tuberculosis? Tuberculosis is subacute to chronic. Pharyngitis is acute, right? Then I might have told you that you should also be inquiring whether the cough is associated with sputum or not, because there are some causes which are associated with sputum, like pneumonia, tuberculosis, and there are some causes where cough is there without sputum, like interstitial lung disease. There will be dry cough. So when you know what to ask from a symptom, your history taking gets better. So for making communication better, just keep talking to people, not just the patients. That's how you feel confident of talking to people, including patients. Second, for history taking, you can make history taking better by reading about symptoms. We call it as symptomatology. I'm not saying that you should do that from Harrison itself, but Harrison is a very beautiful book when you want to learn about symptoms or approaches to symptoms. But any of your bedside examination book will have sufficient initial pages where they talk about how to approach symptoms. Okay, so once you start approaching symptoms as per the protocol, you are now already taking a good history from the patients. Then you will start concentrating on examination. That does not mean that you go and tell your professor, some app, some teacher has told you go step by step. So, sir, right now I'm concentrating on history taking, I don't want to examine. No, you keep doing that, but your effort, where it should be targeted, where it should be directed, that's what I'm telling you. Your effort initially should be targeted at building good rapport with people. Then it should be targeted at being able to take good history. So for that, you spend 2-3 months reading about different common symptoms. Again, I should tell you clearly that don't go behind rare symptoms, rare syndromes, rare. No. Someone who knows a lot about rare rarely becomes a good doctor. You need to know a lot about commons, because commons is what you do, like you deal with day in and out. Cough, you should know in and out. Fever, you should know in and out. Chest pain, you should know in and out. Weakness of body parts, right side, left side, you should know in and out. Dizziness, you should know in and out. Abdominal pain, you should know in and out. Common cases, right? So learn about the common symptoms, and you can definitely ask your teachers like me for medicine or Sandeep for surgery, what are the important symptoms that I should study, right? I will definitely be happy to help. Okay, then you go into examination. I'll tell you very important tips with respect to examination. When you go into examination, take one bit a day. Means your teachers might ask you to do full examination and present the case. Do that, but your attention should be learning one bit a day. So today I begin with general physical examination and there pallor. So today I will only study about pallor, and whatever I've studied I'll go and apply. Means for examination of pallor, this is the method that book has told, or this is the method that sir has told. Apply that to the patient. Patient need not be pale. Just document, like notice as per the examination method whether this patient has pallor or not. So when you keep seeing hundreds of patients, you become pro in recognizing who is pale and who is not, right? Similarly, when you see tens of patients with, you examine tens of patients for icterus, it becomes pretty easy for you to recognize who is having icterus and who is not. So as you start seeing more and more patients, the time you spend on recognizing the abnormalities goes on decreasing. So for examination, inspect, or like I would say examine, because inspection means, we're talking about inspection, palpation. Examine whatever it is, inspection, palpation, percussion. Examine plenty of normals. Plenty of normals. So today I studied about pallor. I'm not in medicine posting. Doesn't matter. You're in surgery posting. Ask the patient to hand over their hand to you and check for pallor. Ask the patient to let you look into their eyes and check for pallor. Nothing you lose. Your ability to detect pallor gets better. That's it. Regardless of where you're posted, right? If you have studied about a particular finding, go and examine that in that patient with consent. And when you keep doing that for multiple patients, somewhere down the line, when you hit someone with an abnormality, you have already accustomed yourself. Your nervous system is trained to notice the normalcy, and it will easily differentiate it from abnormality, and you will recognize, oh, this patient is pale, this patient is having icterus, this patient is having bronchial breathing, this patient is having mid-diastolic murmur. You will recognize. So same applies to all part of examination. Cardiovascular system examination, auscultate all areas for all patients if you have time. You may not hear a murmur because it's not cardiac case. This is CVS case, CNS case. This is surgical case. Is anybody stopping you from putting the stethoscope? If patient is letting you examine, he is okay with it, then auscultate. You will hear normal sounds only if there is no abnormality. But when you hear 100 normals, the 101th patient, if he is having a murmur, your ears will definitely pick it up, right? Examine plenty of normals. And every time you examine, please keep repeating the steps in mind. Okay, so this particular examination, as usual, I should be standing on the right side of the patient. I am supposed to examine it under natural light or broad daylight. So if the light is not natural, I will change up the location of the examination. After that, this is the position of the patient. Okay, now my patient is in that position, and this is the next step, this is the next step. So keep doing that in your mind so that you don't vomit any steps, you don't miss any step, and you do it methodically, because that is how you develop ease of doing examination in the practical exam, when four examiners are constantly staring at you whether you're doing it right or wrong. You will not have to tremble when that happens, right? Examine a plenty. You will pick abnormalities easily. Okay. Then fourth, present cases. So once you feel like basic examination I'm able to do, right? I am able to talk to the patients comfortably. I'm able to win their confidence, so that they give me history. And then when I start taking the history, I'm able to analyze the differentials for symptoms like cough. Okay, these are the possible causes. Fever, these are the possible causes. Shortness of breath, these are the possible causes. And then I'm able to do all basic examination of pallor, icterus, sinuses, clubbing, respiratory system auscultation, cardiovascular system auscultation, percussion. I'm able to do all of these decently or with fair confidence. Then catch hold of someone who is ready to listen and present the cases. Again, to begin with, need not be a senior, need not be a faculty, need not be a professor, could be your batchmate. Just present, because even presentation needs a flow. And when you present few cases, you build that flow. And after that, catch hold of someone who knows the subject a little better than you. Maybe your senior, maybe a senior resident, maybe an assistant professor, maybe a PG, and present cases to them. Whoever is willing to listen and help you better your case presentation. When you present cases, you will have mistakes. And mistakes is not equal to your failure. Mistakes are okay. Keep doing the mistakes. You learn better from mistakes. Like, okay, I'm not supposed to ask this particular question as part of negative history. Professor told. Fair. Okay, I learned. I will not ask next time. That's it. Don't take it to heart, even when someone is overtly critical of you. Because if people are at different levels of understanding, and somehow in the journey we forget from where we started and where we have come, and so many of them feel like, okay, I know a lot, they are also supposed to know, but I don't know why they don't know. They have forgotten that they were also in the same position at the same age. Like when I was a second crop student, I was also fumbling, barely knew anything. I didn't know what questions to ask. what are the symptoms, why do we ask the duration. I didn't have that clarity. It all builds slowly. So we are all in that learning curve. We all go through the same path. Only thing is that some people forget the path they have come, and those people are not able to be empathetic to their juniors, subordinates, or students. So ignore them. I would rather say pardon them for being cruel to you. They don't know that they are being cruel to you. Ignore, concentrate on the path to become a good doctor, right? Mistakes are okay. And when you start realizing that, okay, the mistakes that I'm doing less, like that I'm doing less mistakes on examination side, I'm doing barely any mistakes on history, that is a point where I would suggest you to upgrade yourself to the next level. What is the next level? If you have some rare cases, or if common case, when case presentations happen at larger platforms like inter-college fests or some conferences, jump in. Again, there also people, doctors will bombard you with questions. Don't take it to heart. If you can answer, answer. If not, leave it. But present cases, because I want all of you finally turn out to be a doctor who confidently handles a case from emergency room to clinics to the court of law, and carries the same confidence when there are 1,000 people sitting in an auditorium listening to you present a rare case. And trust me, it is possible. It's not an impossible task. Just follow what I said today. Start working on your communication. If your communication is poor, if you are a good communicator, then start working on history taking, beginning with the symptomatology. And if you have already covered the symptomatology, your history taking is good, then start working on examination. On examination part, take one examination time. Today I will perfect my pallor examination. Today I will perfect my icterus examination. Tomorrow I will perfect my cyanosis examination. Work one at a time. And once your examination part is doing well, then start presenting cases. And when you feel your presentation of cases is also good, then you are already confident. Next, I don't have to say anything. You will take it to next level. That's it from me here. I hope I have motivated a little bit through my pep talk for you to spend time seriously in the wards. I'll see you in the next video. Till then, have a good time.